Thromboembolic disease is a very common cause of death. Clinical suspects impose a more careful diagnosis and the research of permanent or transitory risk factors in order to establish prophylaxis and therapy. According to the literature, interruption of inferior caval vein seems to deal with a reduction in mortality but not in morbidity, especially in case of some caval vein filters implant. Nowadays, we dispose of different devices whose rational use, applying a strict peri-implant monitoring protocol, could be safe and effective. Two kinds of caval vein filters are available: definitive filters and retrievable filters, percutaneously implanted by small French size technique. Definitive caval filters represent the tech evolution of partial interruption of inferior caval vein. Indications of such devices implant are recurrent pulmonary embolism in spite of anticoagulant therapy, permanent contraindication to a necessary anticoagulant therapy. Retrievable caval filters are divided in temporary filters and optional filters. Temporary are used in patients with a thromboembolic risk limited to the time of illness, such as the protected thrombolysis in thromboembolic disease, surgical protected thrombectomy, pharmacological impossible or ineffective therapy, conditions of transitory risk, and high-risk pathology. We consider temporary caval filters application important for anesthesia and ICU patients too. On the other hand, optional caval filters are indicated for a residence with intent of temporariness. They can be removed after the corresponding period of cautious time, or they can also be left in situ definitively. We retrospectively studied 62 patients of a general intensive care unit scheduled for definitive, temporary or optional bedside caval vein filters implant. A peri-implant monitoring protocol, including a phlebocavography, an echo-Doppler examination, and coagulation tests was adopted. For our study, no thromboembolic recurrence was registered. We implanted 48 retrievable and only 20 definitive caval vein filters. Endothelial adhesion, residual clot, cranial or caudal aggression, microbial colonization of the filter in absence of infection clinical signs, caval thrombosis, pneumothorax were reported. Deep vein thrombosis was reported as early complication in the 8% of cases. All patients with deep vein thrombosis had a temporary or optional filter implanted. In our cohort, however, definitive caval filters were reserved only to 32% of patients, and they were not associated to deep vein thrombosis as complications. So here are three take-home messages. The first is caval vein filters significantly reduce pulmonary embolism without affecting mortality. The second, generally ICU patients have a transitory thromboembolic risk, so the temporary caval filters has been proved to be a first-line option in our cohort. And the third, a careful monitoring may contribute to a satisfactory outcome in order to promote caval vein filters implant as a safe prophylaxis option in ICU bedside. Thanks.